Hi, I am Dr. Parvez Ahmed Rishi, and this is our presentation about tinnitus. Guys, please like and subscribe my channel. Thank you for that. Tinnitus is a unwanted perception of sound within head in absence of sound from external environment, and so it is the unwanted perception of sound. First thing, it is unwanted. Second thing, it is perception of sound, and third thing, there is no sound. There is absence of sound from the external environment. In the absence of sound from the environment, there is perception of sound in the head, and it is unwanted. The person doesn't like it. This is the definition of tinnitus. So tinnitus can be described as ringing, hissing, buzzing, roaring, and humming. It is RHB or H, ringing, hissing, buzzing, roaring, and humming. So some patient will say he has ringing in ear, somebody will say hissing, some may say buzzing, some may say roaring, or somebody may say humming. And this can be the five most common characteristics of the tinnitus. So we have classified it as subjective tinnitus and objective tinnitus. Subjective tinnitus is sound only heard by patient and associated with abnormalities of auditory system. When something is wrong with the ear, something is wrong with the auditory system, and then there is subjective tinnitus, it is heard by only patient. But if there is objective tinnitus, sound heard by patient and examiner, caused by physical abnormalities that produce sound near or within air, then this is objective tinnitus. Objective tinnitus, you remember doctor, so O from the doctor, and it is heard by doctor also with the bell of the stethoscope or with other means. Disorders associated with subjective tinnitus. What are the causes of subjective tinnitus? What is the association of subjective tinnitus with disorders? What are the diseases it is associated with? So, two-thirds people with tinnitus have disorder causing hearing loss. One-third have idiopathic tinnitus. Out of three people, two will develop hearing loss because they are commonly associated with disorders which causes hearing loss. So 2 out of 3 tinnitus patients will develop hearing loss in the long run. One-third have idiopathic cause, so they may or may not develop. Disorders associated with subjective tinnitus, most commonly associated with disorders causing sensorineural hearing loss. It is age-related, noise-induced, and Meniere's disease. Most commonly associated with disorders. What is tinnitus is most commonly associated with age, noise, and Meniere's disease. Remember three common associations of these three common associations of tinnitus: age-related, noise-induced, Meniere's, and all of these they cause sensorineural hearing loss. Less commonly associated with disorders causing conductive hearing loss. Conductive hearing loss may also occur after tinnitus, or these may be associated with impacted vagus or otosclerosis. It is very rare. It is very rare. Ototoxic drugs, cytotoxic drugs, cisplatin, methotrexate, aminoglycoside, gentamicin, macrolide, quinine, aspirin, NSAID, and loop diuretic. All ototoxic drugs cause subjective tinnitus. Ear infections, otitis media with effusion, chronic suppurative otitis media, neurological disorders, acoustic neuroma, schwannoma, MS, metabolic disorders, hypothyroidism, diabetes, psychological disorders, anxiety, depression, and trauma, ear infections, neurological conditions, metabolic disorders, psychological disorders, and trauma. What do they cause? They cause subjective tinnitus. Guys, remember, ototoxic drugs, cytotoxic, aminoglycoside and macrolide, quinine, aspirin, NSAID, loop diuretic, they cause subjective tinnitus. Uncommonly, subjective tinnitus is associated with cytotoxic drugs and air infections. So, disorders associated with objective tinnitus. Remember, objective tinnitus is heard by, the sound is heard by both the examiner and the patient. Objective tinnitus is very rare. It is due to vascular disorders, arteriovenous malformations, vascular tumors, high output state like anemia, thyrotoxicosis, Paget's disease. Management of tinnitus in primary care assesses underlying cause. So find the underlying cause, treat the underlying cause, refer to ENT, refer to the specialist. If you are working in ENT at the PG level, refer to registrar, refer to consultant. All patients with objective tinnitus. Objective tinnitus, refer patients with subjective tinnitus following hearing test who have associated sensory hearing loss. If whom you have to refer, every patient with objective tinnitus, every patient following hearing test who have sensorineural hearing loss. Tinnitus associated with conductive hearing loss, when treatable, cause identified or managed in primary care. Tinnitus secondary to head or neck injury. Tinnitus of uncertain cause. Tinnitus that is causing distress despite primary care management. Treatment of tinnitus, tinnitus in tertiary care. Treating underlying health condition. For example, if your tinnitus is caused by an airwax buildup, air drop or air irrigation may be used. Correcting hearing loss. Sound therapy, counseling, cognitive behavioral therapy, tinnitus retraining therapy, T or T. Self-help, relaxation, listening to music, sleep hygiene, hobbies and activities, support groups. Seventh nerve facial palsy, lower motor neuron involving forehead, motor supply to the scalp, facial muscle and stapedius. Taste to anterior two-thirds of the tongue. Seventh nerve palsy, lower motor neuron palsy. So it is a lower motor neuron palsy, involves forehead. It is motor supply to scalp, facial muscles, stapedius, taste to anterior two-thirds of the tongue. Remember tiny, it may be due to trauma, that is, it may be neoplastic, infectious or idiopathic. And we have trauma, facial lacerations, blunt trauma, newborn paralysis, parotid tumor, tumor of the external canal, middle ear, metastatic lesions, squamous cell carcinoma, cholesteatoma, acoustic neuroma, herpes zoster oticus, Ramsay-Hunt syndrome, AOM, CSOM, malignant otitis externa, Bell's palsy, although traditionally defined as idiopathic, it is thought to be associated with herpes simplex type 1. Characteristics of peripheral facial paralysis. What are the features of peripheral facial paralysis? Motor, unable to wrinkle forehead, unable to raise eyebrow, unable to wrinkle nasolabial fold, unable to purse lips or show teeth, inability to complete close eye, classified using House-Beckman scale. What is House-Beckman scale, guys? Features of peripheral facial palsy. Paralysis include decreased taste sensation, hyperacusis, reduction of lacrimation, needful head and neck examination. If Ramsay Hunt doctor should give acyclovir. All will get steroid 40 mg prednisolone daily. Eye tapping at night and lacrylube if cannot close eyes. Will get hearing test on the day and subsequent follow-up. Ophthalmology referral. Prognosis depends on. Guys, welcome to this presentation, and we have these are the salivary gland problems. Salivary gland problems can be sialoadenitis, that is calculi in the duct of the salivary gland, sialoadenitis, that is inflammation of the gland duct of the salivary gland, and it may be acute, chronic, and recurrent. Then we have tumors, and then we have other causes. So we have these are the salivary gland problems to be discussed in the coming up slides. We have examination of these, inspect the enlarged gland and all others. All the enlarged glands and non-enlarged glands should be examined. Tender, sialoadenitis, siallithiasis. Non-tender, it may be tumor. So differential diagnosis on the examination, we inspect the enlarged gland, and we inspect all other glands also which are not enlarged. If the enlarged gland is tender, it may be sialoadenitis and siallithiasis, and if it is non-tender, it may be tumor. Then we have more than one gland affected. It may be autoimmune or viral. Example, mumps. So if there is more than one gland affected, it may be autoimmune or viral, for example mumps. Then overlying inflammation might point towards infection. If there is overlying inflammation, it may be infection. Examination, test the facial nerve and inspect the oral cavity. By manual examination may be able to palpate a stone and may be able to express pus from the duct. So guys, inspect the oral cavity, may be able to palpate a stone, may be able to express pus from the duct. Sialoadenitis, 80 to 90% in submandibular gland. So stone is in the submandibular gland. Then 5 to 20% stone may be in the duct of parotid gland. Then we have intermittent pain and swelling at meal times. Sialoadenitis, the characteristic feature is pain and swelling at the meal time. You have to take the history. What happens when you take a major meal? Doctor, I have pain when I take my dinner, when I take my lunch, and my gland becomes swollen. So this is characteristic feature of sialoadenitis. Acidic or spicy foods cause worse symptoms. Usually they come from a function. They say, doc, when I go to a function and this swelling is more and pain is more. Hi guys, we have here sialoadenitis. Swelling appears before and persists after the pain. So dear students, if a person comes to you and says that I get the swelling, then I get the pain, then there is no pain and but swelling is there, then it is sialoadenitis, and most common in 3rd to 6th decade, and very rarely causes complete salivary obstruction. Palpation of submandibular gland. So how we palpate the submandibular gland? We wear a gloves in the left hand or in the right hand, depends if patient has stone in the left side. We wear the gloves in the left hand, and right hand we put outside the mouth near the rim of the mandible, near the area, and from the index finger inside the mouth we try to palpate the gland and try to touch the tip of the left index finger with the tip of the right middle finger, right 2 or 3 fingers, and that is how we palpate left submandibular gland. And for the right submandibular gland, we wear the gloves in the right hand and put the left hand outside near the rim or angle of the mandible, and put the right index finger over the submandibular gland and try to feel the right index finger tip with the left middle finger and the ring finger, and that is how we palpate the right and left submandibular gland duct and submandibular gland. Submandibular gland, also called as Wharton's opening, and we have this is the arrows. You can see the arrows. This is the place where we can palpate these, or the ducts are visible there. Stone inside duct opening. Here you can see this whitish, and you can see this area, that this is the stone inside the duct opening. Copyrighted by the McGraw-Hill companies, with the acknowledgement. All the diagrams are from McGraw-Hill companies, and we acknowledge them, and we really appreciate their photography and their pains they have taken to take the picture. Opening of parotid duct, Stensen's duct adjacent to maxillary second molar. So you can see that how we have used the tongue depressor, how we have used the probe to open the opening of parotid duct. It is known as Stensen's duct adjacent to maxillary second molar. You find where the maxillary adjacent to second molar, where the second molar is, you find it, and the Stensen's duct, the parotid duct, is right at its base. Management of siallithiasis. We have sour foods, talagogues to stimulate saliva flow, and we give massaging the affected gland to promote saliva flow. And management of siallithiasis can include artificial saliva products and frequent small drinks. Antibiotic may be required for episodes of acute inflammation. Referrals not settling. Sialoadenitis most commonly affects the parotid, parotitis. Elderly, dehydrated, debilitated. And pain and fever. Tender swelling with redness may be purulent discharge from the duct. Management of sialoadenitis. Rehydration. Staph aureus is most common organism, flucloxacillin and coamoxicillin. And management of sialoadenitis, refer for admission if fails to improve after five days of antibiotic therapy. Facial nerve involvement requiring IV fluid. So we refer if there is no improvement in 5 days of antibiotic therapy, if there is facial nerve involvement, if they require IV fluid. Prophylaxis, adequate fluid intake, avoid of anticholinergic drugs, good oral hygiene, goggles, stimulation of saliva, example gum chewing. Then we have chronic, usually from partial duct obstruction, and we refer. We have recurrent, consider swabbing any duct discharge, and refer. Then we have tumors, guys, usually more insidious in onset, usually painless, going to be referring under 2-week rule for neck lump. Other autoimmune, it may be Jorgen syndrome, metabolic myxoedema, diabetes mellitus, Cushing's, bulimia, alcoholism, cirrhosis, gout. Drug induced, it is OCP and coproxamol. Viral, maybe mumps. So referrals. 2-week rule. NICE guidelines, CG 27 June 2005. Refer urgently patients with an unexplained lump in the neck of recent onset or a previous undiagnosed lump that has changed over a period of 3 to 6 weeks. An unexplained persistent swelling in the parotid or submandibular gland. An unexplained persistent sore or painful throat. Unilateral unexplained pain in the head and neck area for more than 4 weeks associated with otalgia, but a normal otoscopy. Guys, NICE guidelines 2005, refer urgently. Unexplained lump in neck of recent onset or a previously undiagnosed lump that has changed over a period of 3 to 6 weeks. An unexplained persistent swelling in the parotid or submandibular gland. An unexplained persistent sore or painful throat. Unilateral unexplained pain in the head and neck area for more than 4 weeks associated with otalgia, but a normal otoscope. NICE guidelines continued. Refer urgently patients with unexplained ulceration of the oral mucosa or mass persisting for more than 3 weeks, unexplained red and white patches, including suspected lichen planus of the oral mucosa that are painful or swelling or bleeding. For patients with persistent symptoms, signs related to oral cavity in whom a definitive diagnosis of a benign lesion can be made, refer to follow-up until the symptoms and signs appear. If the symptoms and signs have not disappeared after 6 weeks, make an urgent referral. NICE guidelines continued. Hoarseness, do a chest X-ray and ENT if no abnormality detected, send to ENT for FOL. Refer urgently patients with thyroid swelling associated with any of the following: a solitary nodule increasing in size, a history of neck irradiation, a family history of an endocrine tumor, unexplained hoarseness or voice changes, cervical lymphadenopathy, very young prepubertal patient, patient aged 65 years and older. Guys, refer hoarseness. Refer hoarseness if chest X-ray is normal. Remember this point. Refer urgently patients with a thyroid swelling associated with any of the following. You have following point plus thyroid swelling. You will refer the person to a tertiary center, a solitary nodule increasing in size. The person has a solitary nodule that is increasing in size. Guys, and then a history of neck irradiation, a family history of endocrine tumor, unexplained hoarseness or voice changes, cervical lymphadenopathy. Do not delay referral with treatment and thyroid function tests or ultrasonographic examination. Request thyroid function test in patient with a thyroid swelling without stridor or any of the features listed above. Refer patient with hyperthyroidism and an associated goiter non-urgently to an endocrinologist. Patients with goiter and normal thyroid function test without any of the features listed above should be referred non-urgently. If a person has a thyroid problem already, like hypothyroidism, hyperthyroidism, no need to refer urgently. Thank you guys. Please like and subscribe and please comment.